Welcome to NALIN Intravenous Insulin Chart Education Module, a practical exercise for clinicians. My name's Dr. Anthony Zimmerman. I will be walking you through our intravenous insulin chart protocols. Before we get started, I might answer the question, why did we develop an education module? Well, firstly, insulin is considered a high-risk medication along with other agents such as antibiotics and narcotics. Unfortunately, medication errors in hospital are very common, and amongst them are insulin errors. Staff education is challenging as a result of shift work, movement between areas, and high staff turnover. So we felt that it was important to develop a module that can be accessed on an as-required basis to keep people upskilled. Before we review our protocols, I'd like to spend a little bit of time discussing indications for intravenous insulin use in hospitals. Firstly, I'll start by saying that intravenous insulin is often mistaken by clinicians as being a more dangerous route of administration than subcutaneous insulin administration. This is quite the contrary. Intravenous insulin uses a short-acting insulin. As a result, it has a relatively rapid onset and offset of action when administered via an intravenous route. Our protocols also adjust the intravenous insulin rate according to blood sugar level. As blood sugar level falls, so does the rate of insulin delivery, minimizing the risk of hypoglycemia. Our protocols also accommodate for different levels of insulin resistance and therefore insulin requirement, thereby individualizing an individual's insulin treatment. Indications for intravenous insulin within NALIN include any person who presents with an acute coronary syndrome with known diabetes or newly identified diabetes. In this situation, we encourage intravenous insulin to be used for the first 24 hours of admission. Intravenous insulin is also the cornerstone to treatment in management of diabetes ketoacidosis, also known as DKA, as well as hyperglycemic hyperosmolar state, now termed as HHS and previously known as HONC. Any patient with a blood sugar level of above 18 millimoles per litre should be considered to have intravenous insulin, especially if this is a persistent elevation in hospital. And patients who have extended periods of fasting, particularly patients with type 1 diabetes, for example in the post-operative period, should be considered for intravenous insulin therapy. We have two intravenous charts used at the Lowell McEwen Hospital, a type 1 or DKA type 1 protocol, and then a standard or type 2 protocol. This module does not address management of DKA or HHS. Guidelines for managing these conditions can be found on our PPG. In a nutshell, summarising very quickly, principles for management of DKA include correcting hyperglycemia through delivery of intravenous insulin, careful correction of fluid and electrolyte imbalance, correction of a patient's acidosis, which in part will largely follow addressing these two prior aspects of management, as well as identifying the DKA precipitant and addressing this. It is always important to continue the patient's usual basal insulin in addition to the intravenous insulin protocol. This will facilitate the stopping of intravenous infusion as the DKA resolves and shorten length of hospital stay. Similarly, available on the PPG is our management guideline for HHS. This condition is complicated by severe hyperglycemia, hyperosmolarity, and fluid and electrolyte imbalance. Principles of management of HHS are similar to those of DKA, but the first hour of management in this condition focuses primarily on intravenous fluid administration to correct the deficit prior to administration of intravenous insulin, which shouldn't occur in the first hour of management. Now that we've gone through the background, let's walk through the MR213 or DKA type 1 protocol. You may find it useful to have a copy of this chart in front of you as we go through this process. This will also be important later for our practical exercise. I have highlighted here the part of the MR213 that the medical officer is responsible for completing. This does not mean that their job is done once they have prescribed insulin using this chart. The medical team will need to continue to review these charts on each patient encounter. I've highlighted here the parts of the MR213 chart that nursing staff are responsible for completing. I'm now going to go through the MR213 chart piecemeal for new players. We won't need to do this again in as much detail when we review the MR215 chart. Up in the top right-hand corner of the chart are our patient identifiers. This is where a patient sticky label can be placed on the chart. It goes without saying, but it is very important to make sure that the patient's label actually matches the patient that you are prescribing the insulin for. I have enlarged here the part of the chart which shows the frequency at which BGLs should be checked. This is generally hourly, with the exception to the rule being that a patient's BGL has remained in target, that is less than 10 millimoles per litre, for at least 6 hours. This would be an unusual situation, and so you will find that most patients will require hourly BGL measurements when receiving intravenous insulin with either protocol. As with any prescription, it is important that the prescribing doctor print their name legibly, sign it, and include their contact pager or telephone number. Below the clinician's signature is a reminder for our medical officers to review the intravenous insulin infusion daily. Each chart only accommodates 24 hours worth of insulin administration. If intravenous insulin is to continue beyond 12 midday, the chart should be rewritten on a new page. It is also worth reminding everyone that if the insulin is going to be stopped, long-acting insulin and usual therapy should be continued in the background. Similarly, clinicians are asked to circle either the adult or obstetric target appropriate for their patient. Enlarged here is the part of the chart where nursing staff record the BGL measurement, the insulin infusion rate expressed in units per hour, whether the patient is receiving insulin from column 1, 2, or 3, which we'll discuss in a moment, and also where nursing staff supervising the insulin infusion have signed the infusion. Ketones and hypoglycemia intervention are also documented here, as well as whether a medical officer has been contacted. Above the BGL record is a chart for the BGL to be plotted by nursing staff. There is also a reminder to nursing staff that if patients require column 3 for 4 consecutive measurements and still have not reached target, a medical officer should be contacted to review the patient. It will be the medical officer's responsibility to assess the patient and ask, why is the insulin requirement so high? This could be a sign of ongoing acute illness such as severe infection. It may prompt a consultation with the endocrine team. We do have a special column 4 that the endocrine team will use in special circumstances where insulin requirements are high. Another important point that is worth mentioning at this point is that glucometers have an upper limit threshold and will also record high when the blood sugar level is very high. In this situation, if the patient's BGL does exceed the threshold, they should remain in the existing column until a failure for BGL to improve has been verified by a laboratory plasma glucose measurement. For example, if the plasma glucose was initially 50 millimoles per litre and unable to be measured with the glucometer, and within 1 hour the plasma glucose is confirmed to be 45 millimoles per litre but remains above the threshold for glucose measurement, the patient should remain in their existing column of insulin delivery. The moment you've all been waiting for, discussion of the insulin chart columns. We never know how much insulin a patient will require to restore normoglycemia. For this reason, we have tailored 3 insulin columns to assist with titration of insulin doses in patients requiring intravenous insulin. Patients always begin in column 1. Green means go. After the first hour of treatment, BGL will be measured, and we will ask 2 questions when reviewing this blood glucose level. Is the patient's BGL 10 millimoles per litre or less? And secondly, has the BGL dropped by at least 2.5 millimoles per litre since the last measurement 1 hour ago? If the answer is to either question is yes, the patient should remain in their current column. If the answer to both of these questions is no, the patient will move up a column. Alternatively, how do we move down a column? If the patient's BGL is less than 4 millimoles per litre for 2 consecutive measurements, as would occur in management of hypoglycemia, or if the insulin infusion has been switched off for any reason, when restarting the insulin infusion, the patient will begin in the column below where they started. Highlighted at the bottom of the page is the part of the chart which is the nursing administration record which nursing staff complete when making up each insulin infusion. 50 units of ActRapid insulin is added to 49.5 mils of sodium chloride, resulting in a solution that contains 1 unit of ActRapid insulin for each mil of volume. It is important, as with any medication order, that 2 registered nurses supervise and sign this order. It is also important that when the infusion is stopped, that this is also charted at the bottom of the page. Okay, we've now looked at the MR213 chart in detail. Let's take a quick moment to review the MR215 chart. This is used on all occasions where the patient requires intravenous insulin and does not have known type 1 diabetes, or if they have diabetes of uncertain type and do not have capillary ketones of more than 0.6 millimoles per litre. The outlay of the MR215 chart is identical as that of the DKA type 1 protocol MR213 chart. There are 2 differences with this protocol. Firstly, the label at the top left-hand corner clearly states that this is the standard protocol and it's highlighted in yellow. Unlike the DKA protocol where intravenous insulin infusion switches off when BGL falls below 5 millimoles per litre, in this situation the insulin infusion switches off when a BGL falls below 6.5 millimoles per litre. This is reflected in our 3 columns. The principles of moving up and down between the columns is exactly the same as it is as discussed with the MR213 chart. Before we move on to our practical exercise, let's quickly reflect on some common mistakes which are made by clinicians when using the intravenous charts. The first is not to place an insulin required sticker in the regular medication chart, which alerts nursing staff on their rounds that our patient requires insulin therapy. A second disturbing mistake is when medical staff provide a stat dose of insulin order when BGL is high. There is no role for management of hyperglycemia in this situation. When contacted by nursing staff about a high BGL, medical officers should ask how unwell or how sick is the patient, and this can be quickly ascertained by also requesting a capillary ketone measurement. It is also important to ask why the BGL is high in the first place. It may simply follow a treat or mule from a patient, or alternatively, it could be a reflection of ongoing illness. Finally, another error that we unfortunately see is not charting and or administering subcutaneous long-acting insulin when someone is on an insulin infusion. Continuing the basal insulin via a subcutaneous route when using our protocols facilitates stopping the insulin infusion and shortening length of hospital stay. Okie dokie, let's start with our case study. For this exercise, it would be handy to have the MR213 chart in front of you that you can fill in along the way. I would also suggest that you pause this presentation when you need to fill in information, as I will not be pausing to give you time to complete your chart. Our case is a gentleman who presents with type 1 diabetes to Modbury Hospital, having been unwell for 2 days with gastroenteritis. He admits to missing his Lantus dose the night before hospital presentation. At that assessment at Modbury Hospital at 10 p.m, he has moderate acidosis, normokalemia and normal renal function, with a BSL of 24 millimoles per litre and blood ketones of 6 millimoles per litre. Your assessment is diabetes ketoacidosis. His usual insulin treatment is Lantus 16 units at night and Novorapid, a base dose of 4 units with breakfast and the lunchtime meal and 8 units with the evening meal. Questions that I would like to ask you are, how would you manage his hyperglycemia? As you'd expect from this presentation, there is only one answer to this question. I'd also like you to fill in his intravenous ActRapid infusion chart using the MR213 protocol. And then I'd also ask, what are you going to do with his usual insulin treatment, that is his Lantus and Novorapid, while he receives his intravenous insulin infusion? Our patient clearly needs intravenous insulin using the MR213 DKA type 1 protocol. You can see here that the medical officer has filled in the patient details up in the top right-hand corner, selected a BGL frequency of hourly, selected a BGL target of 7 to 10 millimoles per litre, and printed and signed their name, including their contact details. Nursing staff have made up the insulin infusion and charted this at the bottom of the page, and also entered the BGL measurement and ketone measurement in the appropriate location. With regards to my question about what will be happening with this patient's usual Lantus and Novorapid, the medical officer should chart this on the subcutaneous insulin chart, the MR214, which can be reviewed in a separate module. The long-acting insulin should be administered concurrently with the intravenous insulin infusion to facilitate stopping the intravenous insulin infusion. More quick questions. Which column will the insulin infusion begin in? And what will be the starting insulin infusion rate? Intravenous insulin infusion will always begin in column 1. Green means go. In our case, as our patient's BGL is above 20 millimoles per litre, his starting insulin infusion rate will be 6 units per hour. You can see on the example that nursing staff have filled in the insulin infusion rate and signed it accordingly. Over the course of the next 5 hours, our patient continues to receive intravenous insulin. I would encourage you, if you have time, to pause the presentation here and fill in your own chart, and then answer the question, which column and what insulin infusion rate will our patient be receiving at 3 a.m. Here you can see our completed chart with those measurements and adjustments included. You'll notice that the BGL has improved over the course of the last 5 hours, and our patient has in fact progressed to column 3, receiving 6 units of insulin each hour. Our practical exercise continues. Again, you may need some time to complete this part of the exercise, so I would ask you to pause the presentation to give yourself time. But I'd like you to update your infusion chart for the course of the next 7 hours until 10 a.m. Charting the BGL measurements, the ketones, the column and insulin infusion rate that the patient will be receiving for each hour. What column and infusion rate will our patient be using at 10 a.m.? Here we have our updated insulin infusion chart containing all the BGL measurements, the insulin infusion rate, and which column the patient is lying in at each hour. Sometimes people get tricked with these changes, particularly at 7 a.m. You will note that our patient's BGL at this time fell to 4 millimoles per litre, so his insulin infusion was stopped for 1 hour. Therefore, at 8 a.m, when his BGL was rechecked and had increased to 11 millimoles per litre, possibly a result of preceding breakfast and stopping his insulin infusion rate, when the insulin infusion is restarted, he starts in column 2 rather than column 3. The answer to my question, of course, is column 2, receiving 2 units per hour. Another question, if our patient's blood ketone levels are now less than 0.6 millimoles per litre at this time point, will it be possible to stop our patient's insulin infusion? This slide addresses when the intravenous insulin infusion can be stopped, regardless of whether this is our MR213 or MR215 protocol, and regardless of the indication for use of the intravenous infusion. Firstly, all patients with acute coronary syndrome admitted within NALHN are encouraged to be treated with intravenous insulin for 24 hours, regardless of their BGL, assuming they have diabetes or have been identified as having diabetes at their hospital presentation. In all other conditions, intravenous insulin infusion can be discontinued once the BGL has been essentially at target for 12 hours, and also provided the patient is negative for ketones, that is, a capillary ketone level of less than 0.6 millimoles per litre. Again, a reminder, in type 1 diabetes, it is imperative that our long-acting insulin be on board for at least 6 hours before intravenous insulin can be discontinued. The same applies for type 1 diabetes and insulin pump users. The insulin pump must be back running for at least 6 hours before we're comfortable in stopping the intravenous insulin infusion. Now, some patients may have required a significant amount of insulin when using the intravenous infusion, and if they're insulin naive, a decision may need to be made as to whether it is worth starting regular long-acting basal insulin. We would recommend that in a situation where a patient has required more than 12 units of intravenous insulin over a 24-hour period, that long-acting insulin should be started. To calculate the dose, you add the total amount of intravenous insulin received over 24 hours and give 50% of this as a basal dose. This slide addresses another common question that arises when using our intravenous insulin infusion protocols. What do I do with my patient's usual hypoglycemic therapy? In all cases, whether the patient has type 1 or type 2 diabetes, we would continue the patient's usual long-acting basal insulin while they are receiving their intravenous insulin infusion. This helps facilitate stopping the intravenous insulin infusion, and in the case of type 1 diabetes, will minimize risk of recurrence of ketoacidosis. What do I do with the patient's oral hypoglycemic agents? In many circumstances, it's appropriate to continue these. Just remember that metformin is associated with risk, especially in the context of acute kidney injury, and should be held at this time. And also our SGLT2 inhibitors can be associated with risk of normoglycemic ketoacidosis, particularly in acute illness, and review should occur while patients are in hospital. Just before I finish this module, I want to briefly touch on the management of hypoglycemia. NALHN has a treatment of hypoglycemia management protocol, which is on the back of all subcutaneous insulin charts. Hypoglycemia is defined as a blood glucose level of less than 4 millimoles per litre, irrespective of symptoms, or in the presence of symptoms of hypoglycemia in a situation where capillary glucose is measured to be less than 6 millimoles per litre. The first question that any clinician needs to ask when managing hypoglycemia is it safe to swallow? If the patient is safe to swallow, the first step is to administer 100 ml of carbo test. BGL should be repeated at 15 minutes, and if the BGL remains less than 4 millimoles per litre, another dose of carbo test should be administered, provided the patient, of course, is safe to swallow. In the situation where the patient is unsafe to swallow or unconscious, it will be appropriate to call the MET team and administer intramuscular glucagon as present on the wards in the hypoglycemia kits. Once the BGL is above 4 millimoles per litre, if it is more than 1 hour before the next meal is due, we would encourage administration of the equivalent of 15 grams of complex carbohydrate using the dry biscuit pack, which is within the hypoglycemia management packs. It is also important to notify medical officers so they can come and review the cause of the hypoglycemic event and make necessary adjustments to therapy. It is also important for nursing staff to restock the ward hypo kit. This brings me to the end of this training module. I hope you have found it useful. Please don't hesitate to contact your friendly Diabetes Education Centre or the endocrine team if you have any questions that may have arisen from this module or you'd like to learn more about managing diabetes. Please also don't forget to make time to complete our subcutaneous insulin online training module. If you have any feedback with regards to these modules, don't hesitate to contact me through the Division of Medicine. Thank you for your time.